Hello and welcome. Thank you very much for joining us today. My name is Maryanne Murphy. I'm part of the children's team here in Trinity College and a member of the Child and Family Health Research Strand. And we're delighted to be hosting this seminar series, Innovations in Child Health. And we're really delighted to host today's one, where we have a fantastic panel for this afternoon's webinar. The Trend to Blend: Innovations in Gastrostomy Feeding for Children, Adopting Real Food. So fantastic title. Blended feeding has seen a rise in recent years, and the webinar examines the evidence base around its use. Sarah is joining us. Sarah Naughton, a dietitian, is joining us. I'll introduce her a little bit later. And she's working with children with gastrostomy feeding daily. Linda Branagan, we were really delighted to have as one of our panel today, as a parent. And Dr Carmel Doyle, who's an assistant professor in infectious disability nursing here in Trinity. So we have three presentations today. We have Carmel and Sarah presenting, and Linda's going to give the parents' perspective. So Carmel, I'd be delighted if you could start yours today. Just to note, there's a chat function, and if you have questions, you can pop them in the chat. We won't be raising hands, so please put your questions in the chat and I will make a note of them, and I'll present the questions to our panelists at the end of our webinar. So please use the chat function. Our attendance is still increasing there. People are still joining us on Zoom, so welcome and thank you for coming along this afternoon.
This is a scoping review that I was involved in for myself and some colleagues from TCPHI, the Trinity Centre for Practice Healthcare and Innovation, and Stewards Care actually collaborated on this also. And in redeveloping a policy around blended feeding for the school at Stewards Care, it was important to scope the contemporary literature around the topic, and hence we decided to go with this. So the aim of this presentation is supposed to give you an insight into blended feeding, the topic, and then the scope of our review that we undertook. So I look a little bit at the background, the aim, briefly the methods, and then we look in more detail at the specific findings and conclusions. So in terms of the background to blended feeding, we know that it's not a new concept, but it's increasingly prevalent. And blended tube feeding is usually described as the provision of pureed foods administered via the gastrostomy tube. And blended feed or otherwise blended diet, and you'll see lots of different terms actually used in the literature, and the one that we adopted was blended feed. But blended feeds can refer to any food or drink that is other than water or expressed breast milk or formula, and includes homemade formulas, liquidized feeds, blenderized food, liquidized diet, or pureed table food. So basically any foods that you or I eat that could possibly be blended and put through a bolus feed for gastrostomy. It has certainly intensified in use with children with developmental or acquired conditions who have associated issues such as GI disorders, swallowing difficulties, or those who might have a neuromuscular condition. So we see it used quite a lot in children with intellectual disabilities. The use of commercial formulas, historically displaced the use of blended feeding. So up to the 1970s, blended feeding was actually quite common, and then commercial formulas came on the market, and that was largely due to these control in knowing what the nutritional and calorific content was. And then the advantage of those commercial feeds, of course, is the ease of preparation and the sterile delivery of food. And you could use a pumping mechanism to do it and not use a bolus. So that just gives you a little bit of insight into how blended feeding was overtaken by commercial feed. So in this particular scope and review, the aim was to summarise the published evidence around blended feeding in gastrostomy fed children. And we framed our review using the PRISM extension for scope and review checklist, and we also used Arksy and O'Malley's scope and review method. A number of databases were used, so we used PubMed, PsycInfo, CINAHL, Scopus, AMED and Embase, and it was conducted over 11, well, just over a 10-year period, so August 2011 to December 2022. And you'll see some of the core search terms there, and you can see already that we used a variety of terms for blend and blended and home blend. So there are lots of terms, and we used several of those. So in terms then of our inclusion criteria, well, what we decided to include was papers that addressed information that related to blended feeding, and they must focus on gastrostomy fed children and or their carers. They must be English language, and obviously if research papers that they were peer reviewed in journals. Now we did have grey literature also, so we included things like non-primary research, thesis, reports, conference abstracts, opinions, letters, discussion papers, etc. So there was a wide variety of papers reviewed. In terms of this particular diagram, so this is our PRISM, and that details the breadth of the literature that was searched. And you'll see at the start we identified over 9,000 papers, and that was in the end whittled down to what was included in the review, which was actually 99 papers, or 59 papers, sorry, 59. So then in terms of the study design, there were 59 papers in total, and this particular slide gives you a summary, and I won't go into detail on it, but just to say while there were 59 papers included, actually 20 were original research studies. So there was certainly a lot less research papers than we would have liked in terms of the review. In terms of the breadth of the papers and where they were sourced, a lot of the papers were UK based or USA based, and then you'll see there was very few outside of that. In terms of data extraction, what we did was we extracted all of the key findings into a Microsoft Excel spreadsheet, and we used the subheadings, date, year, publication, name of authors, journal, and then the aim of study, sample, methodology, and any summary of findings or conclusions and limitations. And from that, then we delineated our themes. And in total, we had 8 themes, and I'm going to go into those in a little bit more detail here. So the first theme that we looked at was normalizing feeding and social inclusion and parental involvement. And there were 19 papers that addressed this particular area. And having a family meal consisting of normal foods and the ability to have control over food choices was a really important part of including children in mealtime. And that was cited by several of those papers. It was also noted that actually it aided the psychosocial value of the feeding process, and it allowed for some regaining of control of a basic need for a child. So it's very important for parents to feel that they were actually able to feed their children other than from a bag of commercial food. Other papers acknowledged that the ingredients were readily available when shopping in supermarkets. There was a wider social benefit, the relationship between child and parent, and allowing families to actually become involved in the tube feeding process was something that was cited also. And certainly dietitians acknowledge that blended feeding encourages the social aspect of eating rather than solely for nutritional purposes. And then also the time spent attached to a feeding pump was seen to be reduced because we don't use pumps with this type of feeding. In terms of physical well-being, this was well cited, and actually 37 papers referred to physical well-being of the child, and caregivers reported happier and healthier children. improvements in feeding and volume tolerance, reduction in gagging and retching, a decreased aversion to feeding, the condition of the child's skin, bowel regularity and alertness were all cited as possible improvements. And so too were symptoms of diarrhea, where there was a reduction in incidence of diarrhea and vomiting, and also a reduction in the need for stool softeners to alleviate constipation. There was also notably a reduction in physical symptoms such as reflux, vomiting, but also improvement in statistical measures, so anthropometric measures such as those that would show visible improvement in the appearance, but also with weight gain measurement. It was also noted in one particular paper that some children prescribed GI meds were actually able to cease those medications or wean off them or wean to a lower dose. And also where food intolerance was present, tube feeding intolerance was decreased where blended feeding was implemented. So the need for dietitian and health professional support was also evident. 14 papers looked at this. There was a sense that there was a need for early conversations or discussions on the process of commencing blended diet, but also some families it was noted some families don't seek support to blended feed as they were aware the dietitians might be unwilling to consider it or uncomfortable supporting that. And that was important to note. There's a real need for development of dietetic models of care and resources, and dietitians have been highlighted as a really valuable resource, and they can assert their role as nutritional experts, especially those familiar with blended feeding, and therefore can provide guidance around that. And that was certainly something that was important. Blended feeding can also be administered safely and can meet the nutrient needs of the child if it's managed by a knowledgeable medical team. And that process of transitioning to blended feeding, while it's overwhelming, where the decisions being considered to introduce the feed, there should really be consultation with all of the clinicians, the relevant clinicians who have expertise in that particular area. So it's really seeing that dietitians could play a key role by generating clinical, real world evidence, translating that knowledge, and also becoming real advocates for the families of children who wish to use blended feeds. So positive outcomes with blended feeding have been highlighted by dietitians in clinical practice, and that was noted in some of the papers that we looked at also. It was also important to understand the risks associated with blended feeds, and 9 papers looked at risks in particular. And risks include inadequate or unbalanced nutritional intake, maybe microbial contamination, tube clogging, and these might all potentially cause unintended harm without knowledge and guidance. There was a single case study reported that there was a vitamin K deficiency in a teenager who was fed using blended diet, but as I say, that was a single report and that didn't appear in other literature. Unlike commercial prepared foods that are pre-packaged, obviously blended feeding don't undergo the canning process, and that was certainly something that might be of concern for some users. Bacterial contamination is concerned in terms of safe sanitary feeding practices that will be required when blended feeding, and with these in place, obviously bacterial contamination is minimised. So that's important to note. Another theme that was evident was around the lack of guidelines being available and the need for caregiver engagement alongside detailed protocols and guidelines. And dietitians acknowledged they would feel more confident supporting someone wanting to blended feed if there were adequate evidence-based guidelines in place. And while clinicians might be hesitant in their support of blended feeding, they also acknowledge that they have a responsibility to assess blended feed use in terms of an alternative to commercial feeds so that they can actually provide guidance to support nutritional intake and accommodate blended feeding where possible. So that was something that we noted in the literature, but also we noted that there was a real lack of research in the field, and that resulted in the absence then of clear guidelines and inconsistencies in support, which was important to note. 13 papers looked or talked about the need for training and education. And education delivered by a dietitian is essential when blended feeding and should encompass proper food handling practices and detail regarding the adjustments for adequate nutrition. There's also a need for standardised training to incorporate blended feed as an option and not just commercial feed, but also training for healthcare professionals. So around things like screening of potential users, and also maybe looking at the evaluation of baseline and regular follow-ups for those who would have it implemented. And a real need for training and information to support dietitians and dietetic students in the implementation of blended feeding, and also suggest the efficacy of a practical training course that could actually be used to enhance professional competence in that particular area. Cost of blended feeding was cited briefly in 3 papers, and economically it suggested that homemade or blended feed presents a lower cost because the increased cost of dietetic input by the health service would actually be offset by the saving in terms of enteral formula and plastic feeding consumables and giving sets and the like. So that was worth noting. And then the last theme that we identified was around the barriers to blended feeding. And I think it's actually really important that we consider those, because there were common barriers cited, and one of them being risk of tube occlusion, compromising enteral access, maybe possibly inadequacy in terms of nutrition, and then also the risk of food contamination. Often it's a higher viscosity in a blended feed than that of a commercial feed, and therefore there was concern shown around that, but notably those blockages were easily resolved with a water flush. And while challenges exist as a possible alternative to commercial formulas, it's important to take into consideration, I suppose, time, insurance and governance, nutritional adequacy, and food safety also. So in terms of concluding, I suppose what started as a parent-driven focus has certainly shifted to a professional focus now, with more and more dietitians and pediatric teams looking at the option of blended feeding. While many papers exist, there's a real lack of contemporary evidence that supports or refutes the opinions on blended feeding. So certainly more research is required in the field. We certainly know that blended feeding has a role in minimising the need for invasive treatments in GI disorders, and it can address symptoms. So therefore, that's something worth considering. And while it may seem obvious, parents and professionals can take collaborative approaches to ensure blended feeding is adopted if that's actually required. And that's important to provide flexibility in care needs. And then also to look at new developments, because even, in the time that we have been scoping the literature, things there's constant publications. So look at contemporary guidance, and we know the British Dietetic Association published their practice toolkit in 2021, and Ireland followed suit in 2022 with a resource pack and position statement and recommendations, and that has been hugely beneficial for dietitians and families and supports the implementation. Also, there's an ongoing study in the UK. Mark O'Neill is looking at various types of diets for gastrostomy feeding, and if you have an interest in that, to just click on that link, YouTube, and it just demonstrates the ever-changing area of practice in this particular field. So thank you to my colleagues in both TCPHI and Stewards, and if anybody after the webinar has questions, please feel free to contact me at that email address.
Thank you, Carmel. That was a great presentation of very compelling evidence to be examining this area. So thank you for that. And as Carmel mentioned, please put any questions in the chat and we'll address them later in this webinar. I'm delighted now to welcome Sarah Naughton, who is a dietitian, which Carmen referred to as an important part of this process. Sarah is a dietitian in a Northeast Kildare community, our disability network, the community disability network team, and she's also a dietitian with the Laura Lynn. So we're absolutely delighted to welcome Sarah here today. Sarah's going to share her slides now. Thanks, Sarah.
Thank you very much to Trinity Nursing for inviting me to talk to you today about use of blended food by tube. And one of the titles interwoven in the talk today was talking about the trend to blend. And really, at this stage, it's much more than a trend. It's really tried and tested, and it's a method of feeding children that really is kind of well trusted at this stage. And a lot of the studies kind of point in that direction. And I just want to acknowledge my two employers. I work for the North Kildare Children's Disability Network team and Laura Lynn, and I just want to thank them for giving me the time to present today and in the preparation of the talk. The dietitian's role in advising families on the use of blended diet will be kind of summarized as this. The dietitian assesses the suitability of the blended diet for the child, or vice versa, the child for the blended diet. And I'll go through that in a few minutes because it's not suitable for everybody. It's the dietitian's role as well to advise on the content of the blended diet, just to make sure that all the nutrients are covered. We talk about macronutrients, we talk about micronutrients. Macronutrients is the energy, protein, carbohydrate and fat, and then the micronutrients are the vitamins and minerals that we all look at as well. The dietitian also advises on the consistency of the feed to make sure that it'll go down through the tubing well, and that it's providing the right amount of nutrients versus the right amount of hydration as well. So there's a nice little balance between hydration and nutrition, but also the feed has to flow enough that it doesn't clog the tube. And there is a little bit of education involved as well on food safety and storage and the practicalities of food hygiene in the home to avoid the risk of food contamination. But really, just in observation and in using blended diet with children over the years, I have never seen any foodborne infection as a result of using blended diet through the tube. It's also the dietitian's role to calculate out the nutritional adequacy of the overall intake. So not just on one day or one meal, but just really on a kind of a weekly or a monthly, yearly basis, that the child is receiving all they need through their tube. And very often it might be a full blended diet that a child uses. It might be partial. So there might be a certain amount of conventional formula or feed used in conjunction with a number of blended feeds. So it doesn't necessarily have to be an all or nothing type of a thing. And the dietitian will also monitor the child's response to using the blended diet, will be looking at their weight, their growth, their overall hydration. Their biochemistry might have to be checked if they're a stable child living at home. Maybe annually is enough, just to have a look at the vitamin levels in their bloods, and just to make sure that they're receiving all they should do. And their bowel motions as well need to be looked at too. So where do we begin as a dietitian? Like, where does the dietitian begin? Well, a parent might approach the dietitian looking for advice on the blended diet, or it might be the other way around, where the child is not really thriving on commercial formula, and it might be the dietitian who suggests to the parent, will we have a look at this? And by not thriving, I kind of mean some children using commercial formula over a very long period of time might be struggling with symptoms of reflux, vomiting, just a general failure to thrive, bloating, wind in their tummy, abdominal pain, and kind of fluctuating bowel motions, sometimes constipation, sometimes diarrhea, or just a kind of an unpredictable pattern. And in conjunction with the dietitian, there may have been many months or years of trialing different types of feeds, different timing, and different volumes with no improvement. But from the dietitian's point of view, embarking on a blended diet is not necessarily kind of a last resort, although sometimes it can really be, because it's quite onerous on a family to where they're kind of not really wanting to use a blended diet to start this process, because it demands a lot of time, effort, even room in terms of storage and preparation of feeds and freezing them and stuff. So it's quite an onerous task. However, for some parents, it might be a first line of treatment. And it happens very often where we're looking at a child who's moving onto tube feeding for the first time. Families very often feel the loss of providing their own nutrition to their child as being quite devastating. And providing blended diet sometimes is a means to alleviating that difficulty for a family. They might be really interested in provision of whole foods or food prepared at home, and just the inclusion of the child at the center of kind of the food and family. And a lot of the research also points in the direction of a blended diet certainly not being harmful and very often being associated with positive benefits. There's two particular studies that I'll just point to here. The Boston Children's Study was carried out in 2019, and they looked at 70 children between the ages of 0 and 18 who were already receiving blended diet, and just compare those against age-matched children who were receiving commercial formula. And they did find that visits to the emergency department were reduced by 43%, total hospital admissions were reduced by 53%, and respiratory-related admissions were reduced by 67% in the group that were fed blended diet. And there was an increased reported satisfaction reported by families in using blended diet versus commercial feeds. The other study that I'll just mention as well was took place in 2018 in Toronto in Canada, in the Hospital for Sick Children, where 20 children were transferred from commercial formula over to blended formula over a period of 4 weeks. And they found that, just looking at kind of the lower points there, that the micro content of the blended tube was superior to commercial formula. That is, got the vitamins and minerals. There was reduced vomiting. There was increased bacterial diversity and richness in stool samples. And that might be kind of the crux of the whole thing in terms of benefit, that it might be due to the biodiversity of the bacteria in the gut is a little bit more plentiful, or maybe a lot more plentiful, using blended diet, because it's not sterile. The commercial formulas that we use and the way we describe them to be used demands a very sterile environment, and maybe sterility is not really what the child needs in terms of their tube feed. They might need a little challenge with a more diverse flora in their gut. And apart from then, one of the other kind of benefits may well be as well just the components of the diet that you can't really see, just I suppose in terms of not so much the vitamins and minerals, but kind of the blended up bacteria, the kind of the salts and richness it gives. The fibers as well, kind of, the soluble fibers and not quite so soluble fibers, they all kind of go into a blended feed. And one of the other more interesting results of the study as well was that they found that 50% more calories were required for a child using blended diet to maintain their body mass index. And that suggests that more work is required by the gut to assimilate and digest this food. So they're using up a little bit more energy. It's giving their gut more work to do. They're releasing more kind of heat generated by digestion as well. So that's kind of accounts for some of the loss. So inclusion requirements. I just want to check my time here just to make sure. Yeah, that's okay. Inclusion requirements. Which child will be suitable for using a blended diet? Well, first of all, the child must be medically stable. A child that's very fragile, who's going in and out to hospital quite a lot, particularly to ICU, may not be kind of stable enough at that particular time to try a blended diet. They must also be over 6 months of age, simply because we tend not to give solids at all to children under 6 months. They must be fed into the stomach. Children with a jejunostomy tube wouldn't be suitable because the jejunum is not a storage area. The stomach is a storage organ, so the jejunum is not. It's preferable to have a slightly larger size PEG tube to prevent blockaging. And it's not so much that the PEG tube itself blocks, it's more the extension tube that we use for feeding. They can block as well. But I'll talk a tiny bit more about tube blockage a little later on. They must have a mature stomach as well. And they shouldn't be volume restricted. So maybe if they have a medical condition, for example, a renal condition, a heart failure type of condition where volume is restricted, they may not be eligible simply because the diet is much more, it contains an awful lot more fluid. And they must not be on a continuous feed either because, well, for two reasons in particular. Most of these type of blended diets won't be compatible with a pump. They block the tubes and everything. And also the hang time is important, that the home blended feed, you can't let it be sitting in a reservoir being delivered over 4 hours. It has to be delivered fairly promptly, fairly smartly in under 2 hours, so that it doesn't become contaminated, because it's not a sterile feed like the other commercial feeds that can hang for longer periods of time. And the parents must also have a very reasonable understanding of food hygiene and food preparation in their home to be able to manage making the feeds and storing the feeds and freezing. Some of the problems that result, that are possible to result from using blended diet, tube clogging is one of them, but it tends to be something that you can kind of, like using the syringe kind of smartly, you can kind of unclog a tube as well. But using a feed, your blended feed that's well broken down, well blended and sieved as well, if necessary, will help prevent tube clogging. And that's another reason as well where PEG tubes, kind of a well-established PEG tube, can be used, because a lot of the Mikey buttons and things, they can be replaced very easily as well. So even if the tube does clog or block, it's not a disaster. Another problem could be feeds not being nutritionally complete. So working closely with your dietitian to establish the contents of your blended diet is important, so that it's complete in the vitamins and minerals that you need. It's, it has enough protein, it has enough energy. Some particular foodstuffs don't blend down too well. Some things like seeds, raspberry seeds, grains and stuff need to be avoided because they don't tend to blend very well. And in using those type of foods, you need to sieve and blend the feed just to take out those little kind of remaining seeds that might block the tube. And it's important to make sure that you're not juicing versus blending. With juicing, you tend to kind of use fruits, sieve them, you kind of take out all that lovely soluble fiber, where blending, you don't do that. You're getting kind of, all the nutrients from the food. The water content is important as well, that it's not too much, not too little. A lot of these feeds end up being low in sodium too, so you might need advice from your dietitian about using a little extra sodium, particularly in the summertime. And essential fatty acids also sometimes can be overlooked a little bit, and the dietitian will give you advice about using essential fatty acids. They might be added in the form of walnut oil or rapeseed oil, and fish oils as well, or using kind of fresh fish like salmon and mackerel and stuff like that in feeds can also be helpful. Foodborne illness is one that's often on the list of problems, but I have never come across it. Allergic response is there simply because you might have a child who has been using commercial formula for many, many years and hasn't have had the challenge of taking in any kind of maybe milk-based foods or gluten or soy-containing products. So each food, if you're embarking for the very first time, should be added kind of, you know, in a piecemeal sort of a fashion. And for unexpected kind of admissions to hospital, you would need to have kind of a fallback plan as well for emergencies. And I just want to just give you kind of two different examples of what a blended meal might look like in terms of contents. So this could be a sample breakfast that would contain ready rec, super milk, bit of maple syrup, an apple and almond butter. And the reason that you're combining those sort of foods is that you're getting your carbohydrate from your milk and your ready rec. The maple syrup is adding a little bit of energy as well. I just want to get rid of that from my screen. It's annoying me there. And the almond butter is giving you some fat. It's bringing up the calorie content. And you have plenty of micronutrients in ready rec. There's a lot of vitamins and minerals added to it. It's really high in calcium. You know, so overall, the blend is really, really good in terms of nutrients. And I just have a note there, pay attention to the base liquid that you're using. That it's not always water necessarily, that you might be using cow's milk or infant formula as a base, but the dietitian will point you in the right way in so far as how much you have to use over the course of the day or the week. And some foods kind of, you know, are really culpable in blocking tubes. So string beans are one of them, the seeds in blueberries and raspberries. Fruit skins have to be paid attention to as well. But you can work through recipes with your family as well. And some foods kind of tend to kind of gum up in the blender. Bread and muffins would be one of them that are kind of clogging and more difficult to blend. Sorry, now and I just kind of put in just a dinner type recipe as well, just for variety. That one would be based on potatoes, turkey meat, vegetables, cranberry sauce. Again, it brings up the calories as well, as does the olive oil as well, and it gives a nice mix of the essential fatty acids. And milk is used in this instance as the kind of the liquefier, just to give the right consistency. And very often carbohydrates sometimes can be a problem. You know, some of the carbohydrates would clog the tube, so you know, you'd be thinking about breads and pastas sometimes are kind of clogging. So the carbohydrates that mix very well with in a blend would be potatoes, rice, for example. Polenta is another one that kind of mixes nicely. So my job would be kind of also advising kind of families on, you know, different types of foods to use and different varieties. So that kind of brings it pretty much to a conclusion. I've just included some further reading resources there that you can look at later on, kind of, you know, maybe in the recording. A lot of them are online presentations and downloads. And then at the end there's a nice handbook that is really very useful for families for recipes, you know, just to give them a little advice on using different foods. So thank you very much for listening. I'll stop sharing my screen now. Thank you.
Thank you, Sarah. That was a great follow-on from Carmel's presentation of the evidence, so thank you so much. And now we're excited to, I'm excited to introduce Linda Branagan, who's our parent participant here today. Linda's an associate solicitor and a mother of 3 boys. She qualified as solicitor in January 2000, having begun her journey to qualification approximately, well, a few years earlier. Following the birth of her youngest son, Dylan, who has profound cerebral palsy, Linda managed to complete her FE1 examinations and attend the Law Society Professional Practice course. Not only that, she went on then to win an award, the James Sullivan Memorial Prize, for the best performance in her law exams. And we're delighted here to have Linda tell you her personal story of her boy, Dylan, and her experience of blended feeding. Thank you, Linda.
Thanks so much, Maryanne, for that introduction. And I'd like to thank all the TUD team, the Trinity College team, for welcoming me on the panel today. It's an issue that I'm very passionate about. So my journey began in 2012 when I gave birth to Dylan, who was born with profound dystonic cerebral palsy. It was an absolute shock to ourselves, like to our family. We were told that Dylan was extremely ill, would more than likely not survive due to his profound disability. I remember one doctor saying to me that we would be feeding Dylan just to make him comfortable, and that he would struggle with all aspects of independent living. And as the years went on, Dylan struggled absolutely, undoubtedly, but mostly in relation to his feeding. And I kept going back to this one thing that the neonatologist said to me: you'll be feeding him to make him comfortable. Whereas feeding Dylan with cosmetic food was not making him comfortable at all. In fact, when he was about 1.5 years, he was hospitalized with gastrointestinal issues, which were pretty severe. And he was hospitalized for about a week. So as the years were going on, in the beginning, I would feed Dylan with these cosmetic blends, and the cosmetic formula food, and he would undoubtedly vomit with every feed. So we would have to time the feeds. We would have to position them in a certain way to make sure that the feed stayed, in his system. And then we wouldn't be able to travel for about an hour and a half, because of the fear of Dylan vomiting. So it really ruled our whole lives, primarily Dylan's, but every decision that we had to make was all in relation to whether or not Dylan was going to keep down his formula food. So when Dylan was about 2.5 years old, we went away on the holiday of a lifetime, myself, my husband, and our 3 boys. We went to America because we didn't believe that, Dylan was quite well at the time, but we always had this thing in our head that his life was limited and every day was precious, really. But I remember the day that I decided to change to a blended feed. It wasn't a decision that I made, it was a decision that Dylan made. He was basically telling me, although non-verbal, that he just couldn't handle these formula feeds anymore. And my friend, whose house that we were staying in on holidays, had a super duper blender called a Vitamix blender, and he was blending liquid in it. And I asked him one day if I could blend food, and I blended some carrots and some potatoes and some butter and milk. And I gave it to Dylan. I was completely confident about it. I gave it to Dylan. I think I gave him 120 mils through 2 60 ml syringes, and he didn't vomit. And it was the first time that he didn't vomit in well over 1.5 years. And that was the day I decided, and I began my journey on a blended feed. So literally the minute I came back to Ireland, I connected with my dietitian, and I explained to her what was after happening. And she was quite surprised, because we're talking 10 years ago now at this stage. And it was not unheard of, but it wasn't something that a lot of her patients were trying. So I, being the stubborn parent that I was, kind of insisted, because I had seen a huge change in Dylan's, in his condition, you know, a huge change in his, he was just more comfortable. There was no vomiting at all for the rest of the holiday. I fed him very basic blends, but it was all blended feed. It was all real food. And when I engaged with my dietitian, she realized that it was a journey that we were going to have to go on together. So, and I could see her, you know, I could see where she was coming from too. It was new to her. But she was amazing. She engaged with me, and I asked her, could I have a nutritional chart from her? I needed to know all about the carbohydrate, the fat, the protein, the iron, you know, the requirements that Dylan needed on a daily basis. And she very kindly helped me along the journey. I remember when Dylan was 4 years old, he used to go to respite. And when he was 4 years old, I had to stop the respite because the team, the governance, I suppose, in the respite house just wouldn't, they wouldn't accept blended feeding. So I stopped with the respite there, which we were quite upset about because Dylan really enjoyed his time there. But it wasn't a decision that, it was a very easy decision to make because Dylan had already started his journey on the blended diet and he hadn't been hospitalized since I started. He was in better form. His life was just a lot better. It was very time consuming for me as a parent to make sure that I, you know, blended his formulas in the right consistency. But I didn't mind. It was the least I could do for him, I felt. And it was great to be able to help him this way and make him more comfortable. I had written down on my notes here that I just went with my gut, excuse the pun. It wasn't really my gut that was in question here, it was Dylan's, and this blended feed was really, really helping. So with the continued support of my dietitian, who I linked in with by email and by phone call, Dylan kept on fighting, so I just kept on feeding. And over the years, I just gained more confidence with it. The social aspect associated with it is amazing. Like even recently, myself and my husband went down to a local coffee shop. We brought Dylan with us. We had coffee and cake, and thanks to this blender, the portable blend jet, Dylan had a blended croissant with some milk. So the social, you know, on a daily basis, socially, it's so much better. Dylan is included in all of the meals that we have, and with our family, he will have Christmas dinner, the exact same as everybody else. He had some of Daddy celebrated a big birthday recently. He had some of Dad's birthday cake blended. You know, it's very important to include him in that way. Recently in school, they introduced the Food Dudes program, and I have 3 children. I have 3 boys, the eldest being 19, and then I have a 16-year-old, and they all did the Food Dudes program as well in school. And I consented to Dylan doing it too. And every single day I engage with him in the morning time, when I'm blending his breakfast, and I tell him what's in his breakfast, and I tell school what's in his breakfast, and they talk to him about the food that was included in his breakfast too. And he brings home, yesterday he brought home a banana, and we were able to talk about the fact that he had one for his breakfast and stuff. And Dylan would be very cognitively aware. Now he's peg fed and wheelchair bound and non-verbal, but understands a lot. So I truly believe that he, you know, is thanking us for starting this journey with him. There's things that I know that Dylan doesn't like. He doesn't like spinach. He doesn't like red peppers. I know this because he has, you know, if he might have a little bit of reflux, or he might have a little bit of regurgitation. So I don't blend things like that. So yeah, I can't thank my team enough in the hospital. my apologies. I don't know what's after happening to my screen there. I can't thank my team enough in the hospital, really, that Dylan attends, because he attends Tala University Hospital, and the neurodisability team there have engaged with me on the blended diet journey for the last 10 years. Dylan's best interests have always been to the forefront with that team. I also wanted to thank Stuart School. I know an awful lot of the schools in the country don't recognise the blended diet, whatever reason it may be, governance or whatever is associated with a decision not to, which I would respect too. But I really do honestly feel blessed that as our journey is progressing over the last 10 years, people are really getting on board, like respite houses. Laura Lynn has always been on board. Dylan has attended Laura Lynn for the last nearly 11 years now. And there was no question with Laura Lynn in relation to the blended feed, which I'm so, grateful for. And thanks to Sarah today as well for those little hints and tips. I'm always looking for resources to assist me in relation to feeding him. But thanks also to, I just want to, as a parent advocate, just a message to the parents out there that are wondering whether or not to do it. Again, excuse the pun, but go with your gut. You are the parent of the child, so use your instinct. Talk to your dietitian, talk to your medical team, see if they agree that it's the best interests of the child, and work with them closely to try it. You'll know if it doesn't work, and if it does work, great. There's a lot of supports around there. There's a Facebook page called Blended Diet UK that I find very helpful. I've also bought a couple of books on blended feeding. You can look on Amazon, and there is a book called The Original Natural Tube Feeding, which I found very, very good. And there's a recent one that's just after coming online as well. It's called Complete Tube Feeding. It's on Amazon too. And that's from an author who's actually peg fed himself. He tube feeds himself. And he's done extensive research engaging with dietitians. So I can give a list of all these resources too. And I can also give my phone number to any parents out there who would like to meet face to face if they're starting this journey, if they have any queries and questions about the journey. I'd love to help in any way.
Thank you, Linda, for an absolutely heartfelt, wonderful presentation. Absolutely wonderful. My children have similar taste to Dylan. They reject spinach and red peppers in this house too. So well done, Dylan. He's not alone there.
Thanks, Maryanne. Thanks, everybody, for taking the time to listen.
Thank you so much.
Thank you.
Yeah, it was absolutely amazing. We'll invite all our presenters upon their camera there now. Sarah, if you're free to join us for a couple of minutes. Thank you. So we've had lovely comments in the chat box thanking you for the presentation, and anybody who wants to contact you, Linda, can maybe contact Carmel, and we can share your contact details. So anybody here any parents or any professionals who'd like to speak to Linda, please feel free to contact Carmel Doyle, and she'll put you in touch with Linda. Can I just ask Sarah, if you don't mind, about your inclusion criteria? Obviously Carmel presented the evidence of the for and against, and mostly for the for, and some of the challenges Sarah mentioned. Sarah, is there situations where it's simply not possible? I know you mentioned the inclusion criteria, but are there some families who are just not able to take this on?
Yes, there are certain I suppose I touched on it when we were talking about kind of maybe children who were quite fragile in and out of hospital, who had a jejunostomy tube. But I suppose if families kind of really don't grasp the whole food hygiene thing, if they don't have the ability to kind of just store the foods, like it is quite onerous, and there's an awful lot of learning involved. So, the odd time kind of, we would maybe try and dissuade a family maybe from trying blended diet if they just didn't have access to all of that equipment that we were talking about. Now, however, you know, we could kind of apply for funding for various things and stuff like that as well. You know, we can assist in that way. But really, once the educational piece is kind of done and the child is medically suitable, then really, yeah, that should be okay.
That's great. So I liked your comment to start your presentation, Sarah. You kind of said the trend to blend, and now it's trending more. So
Yeah.
really, is this becoming is it going to become the norm eventually, and the exception will be the acutely unwell, the continuous feed children? Is that where you'd like to see this going?
I don't think so, you know, and really, like, I don't really have any drive in any way at all.
Yeah, particular, yeah.
You know, that I kind of would use it for a child who just was not doing well on a commercial feed.
Mhm.
Or if a parent was really interested and approached me and said, look, this is what I want to do. I think it would be really, really difficult if every child I saw on peg feeding was on blended diet. You know, it's really onerous, you know, working out
Mhm.
all the calculations and stuff like that. And,
Nutrition.
you
Yeah.
know, and kind of and I can understand kind of from some respite centers and stuff like that, like if you have maybe 1 or 2 children kind of coming in at a time on blended diet, it's fine. But, you know, if you were to have kind of, you know, 7 or 8 children on blended diet at one time, you know, it's quite a task.
Yeah. So but a labor of love, Linda. You definitely did a great justice to the blended feeding story.
It is, yeah. I mean, undoubtedly, I was sitting in the house last night and I realized I didn't have breakfast ready for Dylan this morning. So 12 o'clock last night, I was blending, you know, Weetabix and almond butter and bananas, and so it's a continuous journey, but one that I'm absolutely willing to do, because another point I just wanted to make is when we have children like Dylan, there's very little decisions that we can make on their behalf because they're so medically compromised. We have to put ourselves in the extremely capable hands of the neurodisability teams and the medical teams that are, you know, that are helping us along the way. So if there's any decisions that we can make exclusively for our children, you know, it's just something that I think it comes with confidence. I didn't have a choice with Dylan. Dylan, although non-verbal, told me, Mom, I can't handle this food. He vomited all the time. So, and I can, you know, it's funny, we could be sitting around the table and Dylan will dribble if we're eating. So I say to him, oh God, you're hungry, sweetheart, hold on and I'll get your dinner too. It's extremely inclusive. So it doesn't matter how onerous it is. I feel it's the least I can do for him. But there is a company in America that I know called Real Food Blends, and they link in with a dietitian. It's dietitian based food. And we don't have anything like that over here in Ireland. It would be very helpful if we did, you know, that companies could make these real food blends, and it would be easier to, you know, it would be less time consuming for the parents. But I know I'd say there's about 5 or 6 parents that I'm linked in with through respite homes and through school as well. And we're all more than willing to do it for our children. Although it's onerous and time consuming, we just feel like it's quite essential, and, you know, it's essential for their well-being, really. And we're only too happy to do it for them. But if life was made easier for us in any way, we'd always, you know, be thankful for that too.
Yeah.
Thanks, Linda. You actually led in there to a question in the chat, a question to Sarah, but you've actually answered it. It said, Sarah, is there a market for real food blends by commercial companies? So obviously you're ahead of the curve there.
It's called Real Food Blends. Yeah,
there possibly is. Sorry, Linda, there possibly is a market for something like that. However, I can kind of see it going down. Again, you're kind of nearly going down the sterile route again. So in order to market these sort of foods, they end up pasteurizing them and, you know, you're down. So if it was the beneficial bug side of the feeds that was all beneficial, then you know, you're back to square one, you know, that those
Mhm.
bugs have been excluded as well. However, I'm
Actually,
sure
Sept.
there's a combination of things that are kind of good for children, you know.
Yeah.
And then the other thing is, it doesn't have to be an all or nothing. You know, I come across like lots of children who have a certain amount of commercial formula and maybe only kind of one blended feed a day, you know, so it doesn't have to be an all or nothing thing.
Yeah.
It's great. Tina Kenny's in one of our participants, and Tina is looking to put would like you, Linda, to be in contact with one of her patients in the west of Ireland.
I'd love
so
to.
Tina, as Linda's very generously offered, could you contact Carmel afterwards, Carmel Doyle, and her email is on the webinar information, and we can put you in touch. And lots of beautiful comments here about your story, all of you, and the whole content of the webinar has been very well received by our over 55 participants here at one stage today. So thank you so much to everybody. We're into of time, people are probably going back to work and everything, and there's still loads of comments coming in there. As a coincidence, 1 second, we just read this comment. Presentations, as a coincidence, would have it the first paper from your YouTube story is now being published. So thank you, Mark O'Neill, there for a comment in the chat. That's fantastic. Great. Okay, thank you so much. I'm going to bring this webinar to a close, just a couple of minutes past 2. Thank you so much for our fantastic panel and for our audience for your lovely comments and your lovely questions as well. Thank you. Have a lovely afternoon.
Very much, Maryanne.
Thank you, Maryanne.
Thanks,
you.
everybody.
Take care. Bye-bye. Bye-bye.